Are these the normal problems of teenagers, or is there some kind of pathology or special condition here? And because, it makes a big difference in how you go about responding. I mean, maybe it's the wrong peer group, or is it something organic? And it turned out it was something organic, which was a very, although I told he doesn't always treat patients, he's mostly in the diagnostic side of things. He took this young woman on as a patient, and on the second try, got a tremendously dramatic improvement in her behavior. So on the basis of this report, I asked Hardy to seek Dr. Klindt out. He's a hard man to get a hold of. He's got a very good practice, and in fact, he's just opening the Silicon Valley brain imaging.
Yeah.
And so it's even getting better. And I'm very pleased that he's come here tonight. His credentials are in our newsletter, so I won't go over those, but he's got a very solid background. And so thank you very much for coming.
Okay, thank you. Well, thank you for having me here tonight. And just going to be talking a little bit about brain SPECT imaging and its application to psychiatry. And I think I have lots and lots of slides, so what do we have, about an hour? Or
we can go as late as 9:45 if you want to. That's like,
oh, okay.
It'd be like an hour and 15 minutes.
Okay.
If you maybe if you feel like whatever you want to do, you can take a break at some point, stand up.
All right.
Whatever you want to do.
Yeah, in fact, how long has everybody been here so far?
7:30.
Oh, really? Okay. Well, maybe this would be a good time to everybody, if you want to, maybe stand up, take a little stretch. Yeah. I'm a psychiatrist practicing down in San Jose, and my specialty areas are child and adolescent psychiatry in particular. So my clinical practice is primarily with children and adolescents. So I see a lot of kids with various conditions, attention deficit disorder, of course, learning disabilities, obsessive compulsive disorder, depression, high functioning autism. It pretty much runs the gamut. And a few years back, I was introduced to Dr. Daniel Amen, who's doing brain SPECT imaging work up in Fairfield, and now has actually branched out into, has another clinic down in Newport Beach, and may be moving up to Seattle. And with speaking with him and having him show me the technology and how it works and the usefulness, I really became much more interested. And because initially I was quite skeptical, as most psychiatrists are, of new technologies that we can apply to the field. And so I started sending some patients if they're difficult to diagnose patients, or maybe patients who I had done a thorough assessment on, but and tried a few medications and nothing was working the way it was supposed to. And so with those particular cases, particularly difficult cases, I sent up to Dr. Amen's clinic to have the brain SPECT done. And in getting back the results and the recommendations based on the scan and my clinical history, I actually was getting some very good results. And it was solving a lot of problems which, without the image to look at and that understanding of the underlying physiology of the brain, which was producing the condition or the behaviors, the images were really adding that added piece, which for me was very useful. So in sending more and more cases, it became more and more apparent to me that this was a very useful technology and a very useful tool for psychiatry. So subsequently, I got training, which the state of California, or, the nation basically requires very thorough and very strict criteria to be met to be able to do this technique. And but after several years of training, then was able to obtain a license and actually open a brain imaging clinic myself down here in San Jose. But what we're talking about tonight and looking at are brains. And I like Gary Larson and the Far Side, so I like to start off by just showing all these different brains, which in a lot of ways, in this particular picture, they look very similar. And there are similarities between the functioning of our brains, but there are also very distinct differences as well. So it's when you're treating patients for psychiatric conditions, it's like, you know, looking out on a field of brains and trying to decide and assess what areas are functioning normally, what areas are not, and then how to go about treating the areas that are not. So just to, what I'd like to do tonight is just maybe give you a general introduction to brain SPECT imaging, what it's useful for, the underlying technology associated with it, and then go through some actual clinical cases and some of the images that we see and use in diagnosing and understanding patients better. So brain SPECT imaging basically is useful for many different things. First thing is mild to severe brain trauma, dementia, cognitive decline. Actually, a lot of the work in brain SPECT imaging has been done in these areas: brain trauma, dementia, Alzheimer's. Seizure activity is being used by neurosurgeons to pinpoint where exactly the seizure focus is, if it's not apparent by clinical history. And in doing so, they can go in and extract the area very specifically where the lesion has occurred, and it just makes a much more pinpointed treatment approach. So atypical psychiatric disorders, yes?
What do you mean by trauma?
Trauma would be, you know, a car accident or a kid riding. Yeah, damage. This would be brain trauma that I'm referring to here is, you know, a bump to the brain. So falling off your bike, falling off a you know, skateboard, running into the corner of the desk when you were a kid. And it's very interesting because brain trauma and lasting functional impairment, it doesn't require one to have a severe concussion or to have lost consciousness and have gone into a coma. In fact, if we were to scan, for example, Steve Young or Troy Aikman or Joe Montana or many football players, we would probably find some pretty significant functional loss. So lots of different things that it can be used for. Substance abuse, very dramatic images that are produced. Toxic substances like prenatal exposure to alcohol, drugs, and or other infectious processes affect the brain globally, and those can be seen with SPECT. Temporal lobe dysfunction, and it's being used more and more for forensic and legal evaluations, so to determine the functioning of the individual's brain. And of course, you know, in the legal arena, this type of information can be used either way. You know, so in the courtroom you can just about prove anything, one way or the other. So.
May I ask what you mean by atypical psychiatric disorders?
Well, this would be more conditions that maybe are not responding to traditional therapy and treatment.
They don't respond to traditional schizophrenia.
Right.
Okay.
Yeah, so schizophrenia, but what I'm referring to more here would be like a patient with attention deficit disorder and, say, panic disorder.
How about obsessive compulsive and the work Schwartz is doing on that? Is that?
Yeah, actually I have some examples of that. So obsessive compulsive disorder does show up with a particular pattern of overactivity in the underlying structures of the brain. So I'll sort of go through that as I go on. So it is actually, but this, this is really, it's a tool. It's not an end-all in and of itself. It's not a doctor in a box. It's just a tool that we have available in addition to the clinical history and questionnaires and psychological testing and these sorts of things. The other things that I find it very useful for differentiating between different clinical conditions: attention deficit disorder, anxiety, depression, mood disorders, bipolar, how much of which is going on, and what is really causing the major problems, and where do you start with the treatment. This is very helpful for that. Is it a physiological condition or more behavioral? So if a child, for example, comes in and has a lot of aggressive or violent behaviors, you can determine basically, is it a physiological problem that's going on in the brain, or does the brain look normal and the behaviors therefore are more volitional or behavioral, actually. And very interestingly, following up on response to therapy medications, you can see how the brain function improves over time, and that correlates usually with resolution of symptoms, but with both medication interventions as well as therapy techniques, you can actually see the physiological changes that take place in the brain that correlate with the improvement. So that's really rewarding to be able to follow along with the patient and show them how the brain's improving. So there's a lot of different things that Brain SPECT is useful for. Now this is the machine that I have. It's a NeuroSPECT quadruple-headed camera. SPECT technology and SPECT machines, which are basically just gamma cameras, have been around for many, many years. And of course, is typical, started with single-headed cameras and then dual-headed cameras and triple-headed cameras, and now we have quadruple-headed cameras available. This particular camera is the next generation of SPECT brain imaging devices, and as of right now, this is, I believe, the only one in the United States. So it's pretty exciting to be right on the forefront of technology. Yes?
So this machine shoots radiation into the brain in order to generate the imaging for you?
Good
That's
question.
what gamma rays are, right?
Well, the question is, does this machine shoot gamma rays into the patient in order to obtain the image? And it's actually the other way around. What we do is we inject the medication into the patient, which is a combination of basically two different molecules. One that binds preferentially to the cells of the brain, and the other is technetium, which is a radioactive isotope in the process of decay. It has about a 6-hour half-life, and it emits gamma photons, which are actually pretty low energy photons, and the amount of medication basically and isotope activity that we inject into the patient to get a good image is about 400 times less than the amount that you can inject into a patient, and they're safe to just walk out and go, get on a public bus.
Is that according to the nuclear regulatory commission that allows people to burn bodies in nuclear power? I used to design the equipment that measured the voltage levels of electrons.
Yeah.
When they went through sodium iodide crystals, and I measured how much light came out.
Oh, yeah.
So
Exactly.
Who says that's okay to inject without hurting people?
The Nuclear Regulatory Committee.
That's what I thought, okay.
Yeah.
You should see how much body burn goes through a power plant.
Yeah, although we're not, this isn't a power plant.
Yeah.
You know, we're using like 20 millicuries at the most, which, according to, you know, the medical standards, you know, what they allow is 400 times that amount to be injected into a patient, a procedure done, and then according to the Nuclear Regulatory Committee. Now, you know, obviously you're casting some dispersion on there.
I've watched them work.
So, but apparently, you know, that's a safe amount where the patient who's emitting these gamma photons can walk out and, you know, be in public areas.
Yeah. Just to support your point,
Yeah.
the people you're putting into the machine have problems that are so much deeper than like the little possible radiation they might get. I mean, you know what I'm saying? Like if I'm totally healthy, maybe I don't want to go into your machine, but you're getting people who are very unhealthy.
That's
So,
right.
and if you can improve that, their body will probably heal the radiation that they, I mean, if there's any negative effect, you know.
Well, yeah, you always have to weigh the risks and the benefits, and there is some risk associated with this technique. The amount of, you know, because this is a big issue for people, the amount of, say, radioactivity that one is exposed to with a typical procedure would be roughly equivalent to if you went in and got a chest x-ray, and then that amount of exposure was spread out over about a 2-year period of time. Or just by way of comparison, and a CAT scan, you know, does, as you're mentioning, it's going to be shooting the x-rays into the patient. You get about 5 times the amount of exposure as compared to this particular technique.
Yeah, it's pretty low then, because the x-ray thing, you could stand on top of a 10,000-foot mountain anchor during the day and get more.
That's right. Yeah. So actually pilots, you know, who are flying continuously, you get exposed to a tremendous amount of radiation, actually, in an overall perspective. But anyway, yeah.
What you're injecting?
What are we injecting?
You said you were something that, you know, binds to cells.
Two things.
Yeah, Ceratec. It's called Ceratec, and it's just a combination of technetium and then another molecule that binds to the cells of the brain.
What is this molecule?
I'm going to have to look that up because it just kind of slips my mind right now.
What's
Yes.
the energy released on the technetium? What's the energy level of technetium?
143.
So I think to answer one of these other people's questions, a good way to explain it is that you are relatively transparent to 143 kiloelectron volts.
Correct.
And I'm willing to drink radioactive oxygen all day long and have zero exposure because I'm transparent to it. It goes out of me.
Yeah,
And my absorption level is very small.
that's correct. And actually, you know, well, as you know, the damage that's done is not by radiation, is not so much the direct damage that's inflicted upon the physical matter in the cell itself. It's on the water that's inside your cells, and then creating free radicals and ionizing the water as it goes through. So that's what creates the you know, the damage actually. So the burns that, you know, you're referring to, that's sort of the accumulation of these different, say, gamma photons or other ionizing radiation going right through somebody. But when it passes through, it's ionizing, you know, hundreds of millions probably of the water molecules, and then that accumulation and over time creates the damage. So in the overall scheme of things, this little piddly, you know, machine and the amount of radioactivity that we're actually exposing people to is pretty minuscule. And, you know, not negligible because you do have to weigh the risks, but I think for the population that we are scanning, I think your, you know, statements are very
It's like the
correct.
gentleman's thyroid. I mean, they didn't take it out because of no reason. They thought there was a bigger harm. So there's always these trade-offs.
Yeah. So, what?
Just
Yes.
one other question.
Mhm.
What about allergic reactions?
Yeah, the question is allergic reactions, which really don't occur.
don't occur.
Yeah.
Because I was injected with radioactive iodine, and I was very allergic to it.
Yeah, iodine is a much larger molecule. Plus, there may have been a dye, in there and associated with that. So that's usually what people will have the allergic reaction to. And this particular medicine doesn't have any dyes or color. It's basically just this molecule in saline solution. Yeah.
So this is a fantastic discussion, but I would like to kind of get toward the, see the whole thing.
Okay.
We won't make it in.
I know.
We just keep asking these great questions. So, make an opening question, and then maybe at the end we can see how much time we have for questions. But let's hope that we can see more of this, because it's fascinating.
Yeah, this excellent questions, by the way. So I appreciate that, the interest and the level, of your understanding, obviously, is very, very high. Now, this particular machine, this is just an example of some of the images that we can get. And this particular machine has a software where you can do this NeuroGam, which is basically just, it's a Talarak analysis of the data. Which basically what that means is that what this machine can do is it takes the information that is generated from the scan and it puts that information into a idealized brain space, which is a Talarak space. This is a doctor who did actually most of his work of MRI scans and just took brain after brain after brain after brain and looked at the commonalities and came up with sort of a generalized brain. And in doing so, you can then compare and quantitate the various areas of the brain and compare a person's brain with itself 2 months down the line, 6 months down the line, or you can also take this information and put it onto an MRI scan. You can break it down into grids, do Brodmann's areas, or pick out areas that you want to research and look at, and so it just basically gives us a much more quantitative approach and information that can be used both diagnostically as well as for research. And this is an example of where if a patient has an MRI scan and then they come in and do the brain SPECT, you can superimpose the SPECT information over the MRI and get a very precise anatomical localization of the structures that are affected. Now, what I wanted to do now is just quickly go through the different orientation and views, then lead into what normal scans look like, and then look at the clinical conditions.
So, is this glucose metabolism it's showing, or what's it showing? The colors, like
yeah,
showing the metabolism of glucose, or showing electrical activity, or
the question is, what does this actually show? And what it actually is measuring is the blood flow to the different regions of the brain. And the whole presupposition, I guess it would be called, is that blood flow matches activity. The areas of the brain that are the most active are going to receive the highest blood flow because they need the most oxygen, fuel, glucose, basically. So PET scanning, which is positron emission tomography, utilizes glucose and is actually a direct measure of the activity of the different regions. SPECT scanning looks more at the blood flow, so it's more of a regional kind of a image. But that's what we're looking at. So, basically, when we look at the different views, as is typical, you look at transverse, sagittal, frontal. We have the Talarak now, and then isocontour is just the three-dimensional external surface views of the brain. And I'll go through each one of these. So this is the transverse view. Basically, are most of you familiar with the different orientations? Or no? Okay. So transverse view is basically, we're looking at the brain, say like this, and we're just taking slices down this way, okay, as is indicated here. And the way it looks on the actual scan is like this. So here's the front part of the brain, here's the back. So it's as though this is, in this particular view, we're looking at the patient's brain just like this. And up at the top of the scan, we're looking at the very top of the brain. And then as you progress down through the images, you're getting now into the middle parts of the brain, and then down towards the base of the brain, and then finally out. So that's the transverse view. And then the sagittal view is just from the side. So we'd be looking at the brain like this, and we're taking slices basically in this orientation. And so what that looks like is this. And so in this particular view, we're starting on the right-hand side of the brain, and we're moving through on into the middle portions, and then to the left side, the far left side, and then out of the brain. And
so basically you see where more of the radiation is, and that in turn tells you where the blood flow is.
Correct.
Okay.
Yes, that's right. And then this is the coronal or frontal view, so it's like we're looking at the brain just from the head on. Okay? And so in this particular view, this is what we're looking at. So it's like we're starting right at the very top, front tip of the brain, up at the top of the view, and then we're just moving back in this fashion. Okay? So I like to take my patients, when I do a scan and then I present the results to them, I'll take them through the same description so that they can kind of have a conceptual idea of what we're looking at. Now this is an example of an isocontour view, and so we're looking at the surface of the brain. Here's the front, here's the back, and if you notice, it's just a nice, smooth, even distribution of blood flow across the whole surface of the brain. And that's pretty much what a normal brain looks like right there. And then if we were to flip the brain over, that's what we're looking at in this particular view, or the bottom view. So here's the front part of the brain, here's the back. So we're basically looking at the base of the brain. And the area that's very important for attention deficit disorder as well as depression is this prefrontal area, the inferior orbital area right here. And typically in a general population, it's going to be smooth and relatively symmetrical from one side to the other. And then here are the temporal lobes. And so there's a nice smooth, even distribution of blood flow and fairly symmetrical. And just try to keep these images in mind as we progress forward, and you'll see the differences visually. And then with this technology, we're also able to look at the internal structures of the brain. And so typically this is what we're seeing is not a whole lot of activity in the internal structures of the brain. And this right here, this red color represents the most active 15% of that patient's brain. So in this particular view, we just tell the computer basically to subtract the 85% of the brain activity and just highlight for me the most active 15%. This is the number that most closely correlates with the actual cross-section scans. But it's really incredible because we can look, basically right inside the patient's brain and see if there's areas of overactivity primarily here. And then here we're looking at the front part of the brain, and here's the back. The cerebellum, right back here, that's typically the most active area of the brain. And in a normal scan, we will always see this red back in that region there. And then here's just an example of the Tallerack view where red, in this particular view, red is good. Red just represents good, even blood flow. across the whole top surface of the brain and the bottom surface. And then here's just another way of looking at it. And as you can tell, so the colors are relatively arbitrary. I mean, you can use whatever scale that you want to. And I've just chosen the ones that I have because they seem to visually depict the information fairly well. But here's the front part of the brain, here's the back, and the yellow just represents the surface activity. And these little undulations here are just the normal anatomy. And then here's the base of the brain. And this particular image and this rendering, it's a little more sensitive. So you can see more, deviations, but this is a normal brain here. Okay, and then this is just this left side view and the right side view. Okay, and when you notice yourself becoming forgetful, just give it 20 hard cranks, and your memory should be sharp for a good 2 or 3 days. Never one to follow the crowd. Bob has his brain in his. I wouldn't recommend that. Well, you'd be surprised what adolescents are doing these days. Now, just to kind of briefly go over some functional neuroanatomy, and I wanted to talk just real briefly about the prefrontal cortex, cingulate gyrus, the limbic system, basal ganglia, and temporal lobes. And this is, obviously an oversimplification, but these main functional systems of the brain seem to help us to kind of conceptualize and understand how the brain is working. And so we're going to start off talking about the prefrontal area. One time too many, Frank lets his mind wander. So that's what's happening. The prefrontal cortex is the part of your brain which is right up here, very front. And it does a lot of different things for you. It helps you pay attention, helps you stay focused, not get distracted. It helps with it's the part of your brain that keeps you organized, problem solving, critical analytical thinking. When you get problems with the prefrontal area of the brain, you're going to have trouble with attention span, distractibility, impulsivity, disorganization, poor judgment, all these sorts of things, which sounds an awful lot like attention deficit disorder.
Can I ask you a question?
Sure.
Maybe 60, 70 years ago, they used to hammer a thing into there.
Uh-huh.
What was going on?
Well, that was a problem. That's not the way to do things.
No.
But the question was about 60 or 70 years ago, they were hammering something into, the frontal part of the brain. Lobotomy is maybe what you're referring to. Was actually the technique was right up here through the orbital, cavity, because the bones are very thin surrounding the eye. But basically what they would do is just go up and ablate the very front part of the prefrontal area of the brain. And there were mixed results. Some patients got very docile and quiet and calm, who before had been violent and aggressive, but others became impulsive and aggressive and violent. So it was, what they were trying to do basically is, I don't know exactly what they're trying to do. It didn't work very well, yeah. So that's what was happening. So basically, the prefrontal cortex does all these different things for you. And again, if there's problems, you're going to have... Now this is what the image looks like. You can see the decreased blood flow. That's what this represents. Now remember, this is a functional study. So PET scanning, functional MRI, PET scanning looks at the blood flow, the activity, how the brain is actually working, not the anatomy itself. In a CAT scan or an MRI is just looking at the material of the brain, what's actually there, but not how it's functioning. Now, the brain is so richly innervated and, perfused with capillaries. It's like this very fine web. So the blood flow actually looks very much like the structure of the brain. But we're really looking at the function, which is the blood flow to the different regions of the brain. So in comparison, remember, a good healthy prefrontal area has even blood distribution all the way across this individual. You can see these big areas of shadowing, and that just represents marked decreased activity and blood flow in that part of the brain, as well in the temporal lobe region here. So that produces trouble with attention, focus, concentration, these sorts of things.
How many counts are on these images typically?
We get around 12,000.
12,000?
And yeah, and according to the manufacturer specifications and such, says somewhere around 3,000 to 5,000 is adequate to get a good image. And we're actually injecting less material, and the scan itself takes about 10 or 12 minutes. And that's in comparison to like the Picker triple-headed, where it takes like 16 to 18 minutes. And you have to inject a little bit more material to get, and I think they're typically getting maybe around 5,000 counts. So the image quality, this new scanner is actually significantly better, just because we're getting more counts. This is a volcano. So we're going to be talking a little bit about anger and not being able to let go. The cingulate gyrus, which is this part of your brain. It has the function of allowing you to shift attention appropriately, to go with the flow, to not take things real seriously, to be cognitively flexible, which means if you're in a discussion or an argument with somebody, you can kind of step back and say, well, I don't agree with you, but let's compromise here. If you have problems with the cingulate, you can hold on to past hurts, get stuck, be obsessive in your thinking, oppositional behaviors, argumentative, strong-willed. These are the types of things that, getting stuck, basically, addictive behaviors. So the good things that come from a normally active functioning cingulate is cooperation, adaptability, options, and if you have problems, now this is an example of an overactive cingulate. And this is a side view, and you can see, remember in the normal scans, you just see activity in the cerebellar part of the brain, but none up in the front. And so this is a markedly overly active cingulate, and typically what we're seeing with this kind of a presentation, and that's why when I saw the results I did on the patient that he was referring to, I was able to say, it's not like I'm a magician or anything, but it was very likely that with this presentation, this individual is going to be argumentative, going to get stuck, can't let things go, oppositional, obsessive. This is just kind of a funny way of looking at all the different expressions, and so I'm going to be going into the limbic system. And again, I'm just really going over this very quickly in the interest of time. The limbic system is really responsible for generating your mood. It's responsible for sleep-wake cycle, hunger, sex drive, libido, motivation, interest, energy. And when you have problems with the limbic part of your brain, you have typically low energy, sleep-wake cycles disturbed, appetite might go up or down, sex drive goes way down, lack of motivation, just to lose interest in things even that you normally like to do for fun. And typically what we see in a scan of a person who's depressed is this is the limbic area right here, and it's typically overly active. Again, in the normal study, we would not see this red up in this region. It just would be real blue And so the limbic system actually gets more active when a person is depressed. And then for anxiety, the basal ganglia are the part of the brain responsible for that. And the basal ganglia are important for a lot of different things. So integrating movement with feeling, it sort of makes sure that your movements are fluid and predictable. And Parkinson's, of course, is a problem with dopamine production and with the basal ganglia part of the brain. So you can see that that's where you get the cogwheeling and the tremor. And when one starts working with individuals with brain difficulties, and then the normal population, you can really see the incredible intricacy and delicacy of how the brain functions just normally, but the complexity is just incredible. If you have problems with the basal ganglia, anxiety, nervousness, panic attacks, fearfulness, somatic symptoms, stomach upset, peptic ulcer disease, these sorts of things. And typically, there's just more, wanted to go here into the temporal lobes. I'll show you some examples of basal ganglia later. The temporal lobes are the other big functional system of the brain, and the temporal lobes are responsible also for a lot of different things. Understanding and processing language is probably the area that I'm most focused on. Memory, long-term memory in particular. Visual, auditory processing, emotional stability. And when, again, if you have problems with the temporal lobe, particularly the left temporal lobe, which is usually the dominant one, aggressiveness, violent thinking, as well as actions, paranoia, dyslexia, language-based disabilities, emotional lability, real severe mood swings. And so typically, now this right here is an overly active temporal lobe. And so you can just see the red color there basically represents a more, really overly active area. So now, just quickly going into some of the clinical views. Okay, Mr. Ditmars, remember, that brain is only a temporary. So don't think too hard with it. So this is, this is developing science. The brain, how it really functions. It's such a complex thing. We know more than we did, 10 years ago. We don't know very much about how the brain really functions, but we're learning more and more. So. Now, for attention deficit disorder, here is a scan of an individual who had the combined type of ADD. That's a person with difficulty with attention, focus, concentration, as well as impulsivity, some fidgetiness, hyperness. You can see the decreased perfusion right here in the prefrontal area of the brain. And then when this individual is asked to do a concentration task, look at the difference. This is the same person. Marked decreased activity in this prefrontal area, and the temporal lobe shut down. And interestingly, with individuals with ADD, a lot of the time when they get into a situation where they need to be focusing and concentrating, like a classroom or a test or studying, the prefrontal part of their brain, which is supposed to activate, actually shuts down. So they get more scattered, more distracted. Yes?
We're looking at the base of the brain, so is the left side then the right side on this picture?
Correct.
So is there an asymmetry there at all, or do you see, or is it pretty much equally sort of problematic?
No, actually it looks like there's more decreased activity over here on the left side of the brain. So it is asymmetric. Often we will find that. The dysfunction often is not symmetrical. So you can see in cases of attention deficit disorder varying degrees of underactivity in one side to the other.
Does it, with your patients, you get some right, some left, or is it usually lefties that are?
Well,
the ADD, is it always left brain, or the left is more problematic?
No.
Yeah, so you'll get both.
Yeah, usually what we find is that both sides, right and left, have decreased activity. Significant decreased activity. It just may be that the left side is more decreased than the right, but it could be very well, the right is more than the left. So that doesn't seem to correlate real strongly with the degree of the dysfunction, just the total amount of decreased perfusion. And then the same individual who is doing the same concentration task, but they got a dose of Adderall, which is a stimulant, which activates the prefrontal part of the brain. And look at the difference in the improvement. I mean, it's just unbelievable.
Is that the same day?
No, this would be, you need to allow at least 24 hours between scans just to make sure the medication clears out of the system completely. So these were subsequent days.
What is Adderall?
Adderall is a medication. It's a stimulant. It's like Ritalin. It's an amphetamine. It's a combination of maybe 5 different isomers of amphetamine. And if possible, in my particular practice, I try to stay away from the stimulants as much as possible, even though in a lot of cases they work. But we have so many more effective medications now for attention deficit disorder that don't have nearly as many side effects. That the stimulants, at least in my practice, are now maybe a 3rd or 4th choice. But Adderall is amphetamine, basically. And just another example of attention deficit. So here was an individual with the inattentive type of ADD doing a concentration study. And you can see the decreased perfusion, again, temporal lobe region, prefrontal area. Now, when I show these sorts of images to my patients, I mean, I was thinking, oh my goodness, they're going to be very upset because they've got, the holes in their brain. But actually, it gives a lot of hope. Because when you can show somebody that, look, this is why you are having trouble with focus, concentration, and this is how we can address this issue, it makes it much more tangible and much more medical. So it's not just something in their head, it's not just some abstract concept of symptoms that they're being told about. You can actually see a physiological problem. And interestingly, I've found a lot of parents and kids actually get a hope from looking at these images. And then here's the same individual treated again with Adderall. It's not perfect, but a marked improvement. So again, this can be very encouraging. Here's another individual, decreased activity prefrontal area, temporal lobes not functioning well. There's even some decreased activity in the occipital part of the brain. And just very dramatic. And then here, treated with Ritalin. An improvement, not perfect, but these types of studies are where we're getting more information about how the brain functions and what these various medications are doing. And the gentleman was asking me earlier about monoclonal antibodies and other applications of this technology, but another application of SPECT brain imaging is to actually look at the activity of neurotransmitters and receptors. So a lot of the information that we're getting about dopamine function, norepinephrine, serotonin is coming from these types of imaging studies. You'll have to forgive Sidney. The left and right hemispheres of his brain are currently engaged in a struggle for dominance. Okay, now, problems with the cingulate gyrus. This was an adult female obsessive compulsive disorder. We're looking at the frontal view here, and you can see the cingulate. Now, she's got other problems going on, but here's the cingulate, which is markedly overly active. And that's typically what we find with obsessive compulsive disorder is actually overactivity in the cingulate, overactivity in the frontal part of the brain, too much thinking going on. Cingulate gets you stuck on those thoughts, and then usually there's overactivity in the left basal ganglia region, which is the anxiety component. So that triad of findings is very consistent actually with obsessive compulsive disorder. Here's a 13-year-old with oppositional defiant disorder. Here's that overactive cingulate. And again, that's typically what we see in kids who have a tendency to be strong-willed, argumentative, oppositional. So again, and there's actually treatments for this. The serotonin increasers like Paxil, Zoloft, Celexa, they seem to calm that cingulate down. And here's the same individual. We're just looking at the side view, but you can just, it's so dramatic and visual. That's another really valuable thing that I have found, again, is that when you can actually sit down and show patients this, it's just, it gives it so much more meaning.
What's the other treatment? You said there were two. What's the other one? What is the increased serotonin?
Oh, that's primarily the treatment.
Oh, okay.
Yeah, the increase in serotonin levels seems to tone down the cingulate. Here's an adult male had a compulsive gambling problem, but that cingulate is just the commonality. Getting stuck, obsessive, that seems to be the common thread. Here's a chronic pain individual, but he just got obsessed and hyper-focused on the pain problem. And of course pain, you know, there's a psychological component as well as a physiological component. And so with toning down in the cingulate, you know, it didn't make the pain go away, but he wasn't so obsessed with it. I'm just going to keep kind of flipping through. Now here's an individual with depression, and this is a little different view. Here's the front part of the brain, the back part, and this highlighted area here with the black center of the white, that's a markedly overly active area in this particular view. So this, the filtering and the color rendering that I use on my scans, this is what they look like. And typically you just see kind of this beige brown color all through the basal ganglia regions and the limbic area of the brain as well as the frontal area. And so for this particular individual, this is a marked overactivity in the limbic region, and indeed he was experiencing depression. He also has anxiety problems, which we really hadn't picked up on too much. It was sort of overshadowed by the depression. But when I did the scan and we presented the results, it indeed was you know, very helpful in making the diagnosis and the treatment. That's just from a frontal view there. Here's an adult female, and here's what the overactive limbic area looks like. St. John's wort. Great herb for improving your mood, but maybe it's time to cut back the dose. And bipolar disorder. That is a hot brain. And this was a 20-year-old who was in the midst of a manic episode and surprisingly allowed himself to be scanned. But again, here's the front of the brain, here's the back, but look at that. Marked overactivity. It's like the whole brain is just on fire.
What are these blue lines all through the...
Well, the blue lines are just basically, it's the computer's, you know, three-dimensional grid representation of the structure of the brain.
Do you ever view these stereoscopically, or?
No. Yeah, that would be very, that would be the way to go.
I mean, these things, if you just had the ability to rotate it and stuff it, you have a much better feeling for how much volume is actually utilized in these red spots. That might be very thin in one direction, but
correct.
in the other direction.
Yep.
And actually on the computer screen we're able to do that. You know, these are still images or snapshots, so, but now granted the computer screen still is two-dimensional, but we're able to, you know, basically do that three-dimensional appearing rendering. So you can rotate the brain around and determine, exact locations of different areas. But that would add just a whole nother aspect if you could do it stereoscopically. So the image is like out here, and you're rotating it around, kind of like in Disneyland or something.
They have autoscopic displays now that you can without glasses and without anything, you just look at the screen and it appears on the screen.
Incredible. Well, that's the other thing, actually. You raise a good point, because the technology has improved so significantly in the last 4 or 5 years that the images we're getting now are so much more useful. And, there's kind of a joke in nuclear medicine. It used to be called unclear medicine, just because, the images were not nearly as good as they are now. Here's another individual manic episode. Here's an example of a gal with a panic disorder, overactivity right here in the basal ganglia region. Now, you always do these scans in the context of a clinical history. So, you get that information, because we don't want to be treating patients just based on a scan. So you do it in the context of the person and what sort of symptoms they're
For
having.
the bipolar, did you show what the effect of lithium or whatever you were using on the patient?
On that particular, the question is on that patient that had bipolar disorder, was a follow-up scan done after he got treatment to see what it looked like, and not on that individual, but I've got others where I will show you, their response to medication.
Where do you draw the line where the behavior is caused by the blood flow or the blood flow is caused by the behavior? What do you treat? Do you treat the physiology or do you treat the behavior or both?
Well, yeah, that's a great question.
Volition come in there too.
Yeah, but we basically, the direction I come from is that I treat the physiology, okay? I treat the blood flow. So if a kid comes into my office and he's presenting with oppositional and defiant behaviors, and he's argumentative, and he's, all closed down and doesn't want to talk and such, we do the scan. I see a markedly overly active cingulate. I treat the cingulate.
Has anything been discovered with sexual compulsivity at all?
That's, another excellent question. The commonality there does seem to be overactivity in the cingulate, but there's a wide open field of research that's just waiting to happen there. It hasn't been looked at, very closely.
Yeah, I spoke with Al Cooper, by the way, Patrick Carnes. I don't know if you're familiar with those names.
No.
Patrick Carnes is probably the leading expert in sexual compulsion. And Al Cooper, he's at Stanford, did a very, it was somewhat questioned, but he's considered a leading expert on sex on the internet. And I said, both of them asked him, and anything was done regarding the sexual compulsivity or addiction. And surprisingly enough, from Al Cooper, he said, you know something? Nobody has done that. And it's amazing.
I know.
It would seem here this is a marvelous, certainly not to be denied in that study.
Yeah, well, I'm trying to put together a study to look at attention deficit and sexual addiction, because that combination has not been looked at either.
This is I'd love to speak with you later because I've had some conversations on it that might have some impact.
Okay, great. Yeah, so again, it's useful for doing those sorts of studies.
Absolutely.
Temporal lobe problems. This is an individual who had a lot of violence, aggressiveness. Now he's got prefrontal lobe problems, so not good executive control, poor impulse control. And the temporal lobes are not functioning properly, which usually turns into aggressive moodiness, lability, up and down mood swings. And here's an individual with that overactive temporal lobe region. And now what we're finding actually is that overactivity in the left temporal lobe region strongly correlates with violent tendencies. And the other interesting thing, Dr. Raymond has done several scans on violent offenders and serial killers. And the triad, the findings with that group is this isn't the scan of those people, but overactive cingulate, temporal lobe, and underactivity in the prefrontal part of the brain. So those are individuals who have problems with rage and violence from the temporal lobe. They get stuck on thoughts and these impulses, overactive cingulate, and they have very poor impulse control and executive.
Doubt is established because of the evidence here, right?
Yeah.
So it's easier to present that kind of a case than it is to present the case that this is why that happened, or why he did that, right? So it's usually to create reasonable doubt is what this is for.
Yeah, it's the poor individual, with an underlying medical problem. But on the other hand, look at this person's abnormal brain. Are we going to let that person out into society? With this kind of... So you can...
Anyway, the argument against capital punishment.
I'm sorry, what was that?
It becomes an argument against capital punishment. Right. As we have to put people away if we can't fix them, but we don't have to kill them because it's not really something they chose.
Yeah. So this whole arena can get into a huge ethical, moral debate.
But the essential simplicity of all of this actually is really complicated when you get down into the emotions and everything else and the physical aspects of the brain. But it's just this is just basically a snapshot of this is what parts of the brain are working the most. And we can give them some drugs to make this part work more, and this part work less.
Right.
And that's essentially, hopefully, brings somebody into an area of then reason.
Yes.
And reason with them to understand things better. So on the slides that had the Ritalin and these types of things, and that's an amphetamine, right?
Yeah, it's a stimulant.
It's a stimulant.
Yeah.
Essentially, their brain is working in certain areas, right?
Correct.
Okay, a lot of people that I've worked with over the years that have taken Ritalin and stuff like that, these analytical types that work a lot with computers.
Yeah.
By chance, maybe playing with too much Unix is the reason they have attention deficit. But it seemed to me that all of these people had something very in common. And that is they ate a lot, they had tons of carbs, lots of sugar, and then the doctor gave them a drug to take care of their concentration needs. And so with these kinds of snapshots, do you also have all of the data on the size of the person, their eating habits, and all this other stuff that you can go into with, have you tried to make that kid run if he looks like he's got attention deficit and see if his blood flow started to work better in any part of his body? Or?
Yeah, Pat, good point, because now I can know on every individual that's ever been scanned, because there's been, tens of thousands at this point. There is going to be basic information, but their exact diet, food intake, that sort of thing, we don't document that very closely. And unfortunately, in medical school, we really don't get a whole lot of nutrition training. It's not looked at very closely.
Because kids don't move much nowadays, and they keep getting pinned with attention deficit.
But what
they do this. They got twitch thumbs.
Yeah.
That's the most exercising part of their body.
But what we do know, though, is that in general, it does appear that aerobic type exercise 3 to 4 times per week does seem to help kids with ADD. It improves blood flow to the brain, production of neurotransmitters. It's also really helpful for depression as well. And a higher protein, lower carbohydrate diet seems to be a lot better for kids with attention deficit or adults.
So then So we know that the attention deficit from looking at the slides in the brain are a result of a lack of blood flow in certain areas. And then, what was the other one that would more or less be the lack of blood flow? You just mentioned another one, sorry. My brain needs to sleep.
Temporal lobe dysfunction?
Prefrontal cortex.
Prefrontal cortex?
Low activity is bad there, right?
Yes. You're right.
So a lot of this is dealing with a lot of the low activity. And low activity, low blood flow can be handled by more exercise and things like that. John.
Correct. Good sleep, good nutrition, high protein, lower carbohydrate, fluid intake, aerobic exercise. There are some supplements that we can add to the diet, like tyrosine.
So essentially, when you exercise your body, you exercise your brain.
Exactly. Yeah. So
does low blood flow always correlate with decreased activity?
yes, that does seem to be the case.
I don't know that to be the case.
Yeah, because otherwise, the results from the results of these types of scans, PET scans, SPECT scans, would not be useful at all. So the assumption has been, and they've looked at that very closely, but blood flow does seem to very highly correlate with activity, and that's basically the underlying assumption that allows us to even make conclusions. Because if it was variable, then the results would be useless, basically.
There was one case that I studied long ago that made that correlation come to a pot. And that was individuals that had incredibly high caffeine intake.
Ah.
And maybe your units would use that.
No, that was probably me. They were taking regular.
Now, what was the finding, though?
Yeah.
So when people had enormous amounts of caffeine, we found we have more brain activity and hyper functioning. And it's the opposite of the correlation that you just did.
But you mean, well, I'd like to ask you more about that later, but let me continue on. That's very interesting. Here's my little bear slide.
That's good.
Premenstrual syndrome. Now, how are we doing on time?
Well, I think we're doing pretty well. Is everybody comfortable?
Oh yeah.
But this is great stuff.
This is great.
Okay.
Sure.
Premenstrual syndrome, or the periodic dysphoric disorder is a real physiological thing, and I just wanted to show you because this is an interesting topic. Again, we really don't give nearly as much credence and importance to hormonal influences on brain function and moods as we should, and understand that as well. More research is being done in that area now, but it's just a fascinating and very important area. 25-year-old female, 7 days prior to menstruation, overactivity, cingulate. Now, this was an individual who primarily, when not premenstrual, was very rational, calm nurse. When she was premenstrual, aggressive, violent, actually, tried to attack her husband a couple times with a knife. Completely different individual. Now, granted, this is a very severe case. And then this is just a different view. Prefrontal area, and this, high-functioning, productive individual. Decreased activity, temporal lobes, but here, impulse control, modulation of the emotions. And then here's 7 days after menses, completely different brain.
Wow.
Cingulate, and then here, big improvement. So It's really interesting how the brain function changes. Yes?
In Great Britain, PMS can be introduced in court as a legal defense of temporary insanity.
Really?
Very interesting.
Wow, this is substantiated.
Yeah. Well, but I mean, this sort of visually shows us, at least in certain individuals, what is occurring. Here's a 13-year-old who had this is the same situation, 7 days prior to menstruation. The two different views: overactivity in the cingulate, frontal area, temporal lobe. She was prone to violent, aggressive outbursts. Decreased activity prefrontal area, same kind of picture. And then same individual, 7 days after menstruation. Prefrontal area, markedly improved, temporal lobe stabilized. The cingulate still a bit overly active, but much less so. And this correlates with the behavior. Yes?
How was that treated? How was it treated?
Actually, she was treated with a serotonin reuptake inhibitor and some Depakote. The Depakote helps with the temporal lobe area. And the serotonin reuptake, serotonin increasing medication seems to tone down the cingulate. So actually we're finding, medications like Paxil, Zoloft do seem to be helpful for women who are experiencing pretty severe premenstrual symptoms. And with those medications, you can the patient can just take them maybe a few days prior to the premenstrual period of time and then stop taking them, or some choose to take it consistently through the whole month. Yes?
Like in the brain, how deep does this sink? We're looking at the top here on the left. How deep does it go, and would it correspond to and be involved with the corpus callosum, the actual place right between where the two hemispheres meet? Is that the area?
Yeah. No, the cingulate is just inferior to the corpus callosum, or actually it'd be just superior. And
along top.
Yeah, but the corpus callosum is primarily fiber tracts that allow for sort of communication between the two halves of the brain. So there isn't a high blood flow into that part of the brain. So it's more like telephone wires.
This is above that area, right?
Yeah, right. Yeah. Okay. Now, brain trauma, we're asking now, this just shows you, again, this was an individual, a kid who had a history of violence, aggressiveness, conduct disorder, high school, severe problems, and in going back in the history, it was never mentioned that when he was about 2 years old, he had fallen down a flight of stairs, hitting his head several times, was unconscious, and after the scan was done and this was found, then it was, okay, when did the trauma occur? Oh, yes, we remember that. So it's pretty amazing. People really, unless you press them or ask them maybe in 5 different ways, they don't often recall, when they, I had a patient who, when I asked him about brain trauma, no, I never really had anything bad happen. Asked him in a few different ways. Oh, well, yeah, there was that time when I crashed with my bike and the car hit me and the tire, pretty much came right up to my head and was on it, But I wasn't unconscious. I didn't have to go in the hospital. So people a lot of times they'll correlate head trauma with unconscious in the hospital. And so you really have to, well, now what about, this and that? Because what we're finding, even playing soccer and doing, headers can disrupt the function of the brain. This was a gal who was pregnant, and slipped on some cement and fell back, whack. Hit her head in the back, and you can just see this area of decreased activity. It's very dramatic. Here's another individual with
so detecting brain trauma looks pretty easy with this.
Yeah. Usually it's very dramatic. Drugs and alcohol. Again, this is a good way to confront denial. So when you can show an individual, this picture of their brain, you can say the alcohol is doing something detrimental to your brain.
Seems gangrene is setting in.
Yeah. Yeah, that's to make it look even more.
He still got more than 15% of the blue. It's okay.
When you see the effect of smoking.
Was this in the
Yeah.
mm-hmm.
Yes. Nick, actually, what I can do, let me show you. I have a brain, which brain do you want? I can show you afterwards, but there's it shows the effects of tobacco on brain activity. And it does seem to have a real suppressing kind of effect. And it creates a similar scalloping kind of a pattern. There's a 37-year-old male, 17 years, heavy weekend alcohol use. Just look at that. Incredible. There's the top, this should, this is the top portion of the brain.
Yeah.
Basically, it's just not functioning. Incredible. Here's from the side view.
What would be interesting too is to know what the occupations were for a lot of these. I know it's the nurse about it.
Yeah. Well, there's actually also a very interesting videotape and show that was done by Lisa Gibbons hosted it, and it was on alcohol use in adolescence. And they took, a kid who he was actually 21, but he had a heavy history of drinking, and his sister, who was still a teenager, and they scanned his brain, off of alcohol. Then he got intoxicated, and in the presence of a highway patrolman, and they checked with breathalyzer, rescanned his brain, and it's a real dramatic difference. Yeah. And then they scanned the girl's brain, and there was, decreased activity, and it scared her to the point where, at least on the show, she says, "This is, I'm not going to let this continue." So
we saw the PMS.
Yeah.
Up there. Did you have the IMS? Did you have the irritable man syndrome?
Oh, no. I'm trying to get funding for that.
Look at this. Oh, boy,
Jesus.
So again, I'm just going to flip through these. Now this is really an interesting case. This was a guy who came in to be evaluated for attention deficit disorder. I've got ADD, I can't think clearly, I'm disorganized. And any drug use? No. No, not really. Scanned the brain. Dr. Amen actually did this scan, and when he got these results back, he thought there was something wrong with the machine. So he did it, reprocessed it, and it came back the same results. So he took the results to the patient and said, "What is going on here?" "Oh, yes, I have been using heroin, and now I'm on methadone." So heroin just real.
This is just decreased blood flow, right?
Yes.
It's not destruction of the brain.
Correct. Well, yes. Usually, what we're seeing here is just decreased blood flow to that region of the brain. With certain drugs like inhalants or extensive chronic overuse of alcohol, it actually will create or cause brain damage, structural brain damage too. But typically, we're just looking at the blood flow here. It's just another way of looking at the effect of alcohol in the brain. All these blue areas are highlighting decreased areas of activity. This individual actually was brought in by his family, and he's, you know, kind of a functioning alcoholic. The family is very concerned because he's having symptoms, but he goes to work every day, and then, you know, comes home and drinks, I think, a little over a fifth of hard alcohol every night. Just over years and years and years. And when I showed him the results of the scan, I'd never had this happen before, but he actually had like a vasovagal response and got real lightheaded and almost passed out. And I think it was just because it was so impactful. Because when you look at your own brain and it looks like that, it's pretty dramatic.
What's the mechanism? I mean, why is it so irregular?
Well, it's just the alcohol is basically causing a toxic effect over the entire surface of the brain, but some areas are going to be more vulnerable than others. So it's just, it also is going to sort of follow, you know, the brain basically is undulating. So it's just, that scalloping appearance is just an accentuation of the gyri, you know, that are less functional, basically. This is another way of looking at the underactivity. So remember, red is good in this Talarak image. So yellow, underactivity, and green, less active, blue, even less so. So this is that same individual, and you can really see the yellow areas of, you know, marked underactivity.
This slide reminds me of images. Now I know where I saw this. I think it was last month's Popular Science or the month before.
Oh.
They were using this to tell if people were lying.
Oh.
And they had a way of asking questions. I guess they were giving them cards or something like that. And asking them if they were holding the 5 of clubs or something. And they were able to tell, because interpreters didn't ask stuff clearly, they were able to use this as more of a reason to see if any of these Al-Qaeda guys were lying to them. And that was actually in one of the recent Popular Science magazines.
Now that may be the beam technology, you know, where they're looking at sort of, it's like an electroencephalograph that's enhanced and creating this map. And because to my knowledge, you know, you can't really use SPECT for that. But that was, what, a couple months ago? Or?
Yeah.
Okay, so yeah, I'll have to get that.
It's pretty cool.
Very fascinating.
Yeah, it's a new EEG kind of...
Quantitative EEG.
They can kind of do that kind of thing. But the ultimate tool is PET scanning for looking at whether people are lying or not. There's no way that anybody would do a PET scan on a kid because they have a cyclotron nearby to generate the stuff.
Yep.
If they have the cyclotron and they're doing PET scanning, then that's almost a no-brainer to find out whether the guy's talking about his wife or his girlfriend.
Yeah, they took them places, and it was because the interpreters were having trouble clearly communicating everything, so they were able to try to tell if the guy was hiding something.
Wow.
And it was a good article. But like most magazines, it was only a 2-page article.
You remember the month?
Question in the back?
Pardon? It was recent.
Actually, my brother-in-law drank a lot, and then now he can't live alone. And he was saying that he wanted to live alone and back to his house. In fact, because I cleaned out his house today in Belmont. But his nephew took him to a therapist and asked him to remember 6 things, and he couldn't remember one of them. Is there help for him? Is there a way of brain scanning and then certain medication that maybe would help? Or is it too far gone?
Well, a scan would be helpful just in documenting the degree of the dysfunction. But because he has such advanced memory loss and problems, you know, you could almost predict that his brain is going to look like some of these previous ones. Stopping alcohol is going to be the best treatment because not really, unless he stops drinking.
Well, he did stop recently.
Okay.
But he still is not, fully.
Oh yeah. Well, it could take up to 2 years for his brain to regain whatever function it's going to.
And he's in his close to 80s, so that's
Yeah, so that's going to be a factor as well. So probably, actually, there are medications now that we have available that help with cognitive function for individuals with Alzheimer's or dementing processes. So, but if he's got to stay off of the alcohol, because that's just reintroducing this toxic substance.
Well, he's switching to beer with
yeah, it might, taste different. So yeah, you can drink, a case of beer or a martini, they'll kind of do the same thing. So marijuana use.
There were experiments with mice given tetrahydrocannabinol followed by Ritalin that where they became so violent that this was like the Columbine shooting.
Interesting. Well, I've had a lot of cases of teenagers who I've treated who have been using marijuana fairly extensively, and it does produce in those individuals violent, aggressive, irritable, edgy mood swings. And typically, teenagers in particular think, oh, marijuana, it's no big deal. It doesn't do anything. It calms me down. But
the forced treatment with Ritalin afterward created a situation nobody could believe.
Yeah, so let's say you have this kind of a scenario. This is an adult, but an adult or a kid comes in, decreased prefrontal lobe. Maybe you don't know this, and you don't know that they've been smoking marijuana, but they come in and because they're having trouble with motivation and they're forgetful and they're a bit disorganized. So you put them on a stimulant like Ritalin, violence.
Yeah.
So,
how do you know that marijuana was causing this and not like something else, and then he was taking marijuana to, alleviate the fact? You know what I'm saying? Like, so maybe something else was causing the decreased prefrontal lobe, and then marijuana made it feel better. You know what I'm saying? Like rather than assuming marijuana was the cause.
Yeah. Well, the reason is because this is a consistent finding with a lot of different individuals. Now, actually, I've got a case here where let me show you. You were asking about occupations, and this particular individual actually was a physician, and he had this 30-year history of regular marijuana use. You do see this decreased prefrontal lobe activity, perfusion, temporal lobe, but the real picture here is, look at this overactivity, cingulate, basal ganglia, limbic area. He was having a lot of anxiety, panic, depression, and then when he smokes marijuana, now this just shows you, again, this is a different view, but he's off. This is not under the influence of marijuana. The limbic area, all these overactivity areas creating symptoms, and then when he smokes, look at the difference. Now this is a much more normal appearing brain.
That's my case, Your Honor, so marijuana's helping with that.
Right, so he's self-medicating. And now it does not help his, decision-making ability and frontal lobe function. I mean, it's not really helping that part of it, but at least he's calmer, he's not as anxious, not as many mood swings. But once this was discovered, he was switched over to, again, a combination of an anticonvulsant medication which has a calming kind of effect, and a serotonin agent, and it created basically the same effect, but without the, first of all, illegalness of marijuana, and also the unpredictability of it. So there, it is a, a lot of people do self-medicate. Amphetamine use here.
So like drug tests, do you think employers are going to start sending people for scans before they hire them?
Well, that, I hope that doesn't happen, but, or airline pilots,
yeah.
You could make a case for, well, gosh, do you want a guy...
I can see it now. You get off the plane, it's like, it's okay, everybody. This is the picture of your pilot's brain.
Yeah, that's right.
It'll be a good, safe flight.
Yeah, so if you saw something like this, that'd be a little scary. But, that was one proposal, is, part of the screening process for pilots, just have a mandatory brain scan, or for presidents.
Oh, boy. I can see the election posters now.
Who will you vote for? Cocaine. Here's cocaine use. Now this is an interesting case. Here's an adult male, had a many-year history of alcohol, amphetamine, cocaine abuse. And you can see the same scalloping, decreased activity. And then in the undersurface view, just the asymmetry, that you were observing. But this just, look at this, marked decreased activity. I mean, it doesn't hardly look like the brain. And then he stopped using for a year, was rescanned. Look at the difference.
Whoa.
Isn't that amazing? So with your...
How old was this adult?
He's in his 50s. So you were asking about your brother, uncle with the drinking problem. If you stop, your brain often will get better, and then improved, not perfect, but now I do not show these scans to, patients who are using substances, or because with that mentality is basically, well, gosh, if my brain gets better, I'll just keep drinking and partying until
so you
I
just
really have to stop.
Right?
Yeah. So, but actually, this the brain is pretty amazing at regaining. Oh, here it is. That's not quite in focus, but here's the smoking effect. Now, this is just one example, but you can just see kind of the global decreased activity. And then here's a 16-year-old, 2 years of marijuana use. So again, the other area that I find this to be helpful for is for education. So I try to distribute these posters and give them to schools and counselors.
Do you have them on a website?
Yeah, actually, the brainplace.com. Oh no, just brainplace.com. Yeah, is Dr. Amon's website, but he has this poster basically right there. But it's really when, and I have these in my office, so when you get a teenager in and they're talking about how they're smoking marijuana and such, and I just point out, well, okay, but what kind of brain do you want? It really does make an impact. And if nothing else, it makes them think before they're going to use it. I had a couple individuals actually who, they like to have kids over to their house, and it's sort of a gathering place, and they put a few of these up in their pool house, just to have there so they could see. But okay, let's see what else I've got here. Dementia, kind of a global problem. Here again, see, you can see the deterioration of brain function. Here's another way of looking. Here's an individual with Parkinson's dementia. You can see the decreased activity and blood flow up in the top surface of the brain here. then here's how it looks on this Tellerac view. So again, remember, red in this view is very, healthy. So everywhere that you see this yellow and green, not good. Mr. Osborne, may I be excused? My brain is full. Well, it's 10 o'clock. This might be a good place to...
Yeah, that's what it says.
Whoa.
Thank you all for coming, and Bill will probably be willing to stay around for at least a few minutes if you have more questions.
Sure.
Next month we have a great speaker, Bonnie Spur, that I was telling you about. We're talking about sexual vitality. And the following month we have Russell Mills talking about rejuvenation technology. All right.
Well, I should have mentioned this too. I did bring a couple of Dr. Amon's books because I was asked to do that. So if you want to take a look at these, maybe I should have handed them out earlier. But Change Your Brain, Change Your Life is one. And then he also, and this is actually a very good book, and it explains and talks about the SPECT imaging as well as the different types of, the different functional systems of the brain and problems. And then it has like prescriptions and things you can do to help a person who has these kinds of problems, even if it's yourself. And then his most recent book as far as ADD is this Healing ADD. It's kind of a recapitulation of the Change Your Brain, Change Your Life, but it has a little more of a treatment kind of approach to it with some more suggestions. But these are actually quite informative. And,
where does Amon practice?
He has a clinic in Fairfield, and then also in Newport Beach. And then also, I've got some brochures from my clinic here if you want to, yeah, sure. Take one of these and kind of just, you can just pass those out. Yeah.
Bind the toxin that's created when alcohol metabolizes and becomes that thing that makes you feel lousy, which is acetaldehyde. It binds acetaldehyde, and if you take 1 or 2 capsules of N-acetylcysteine, especially if you take with vitamin C and vitamin B, if you drink a lot, you need vitamin B, otherwise you don't even need that, you won't get hangover. It sounds preposterous, but I've tried it myself. My friends have all tried it. Everybody I tell about it, they kind of take one for fun because it's, after all, a very harmless supplement that you can get in a health food store. And then they're amazed, and then they're hooked. So I don't want to see any of you suffering unnecessarily. So enjoy the season. That's just a kind of little.
Is there a proportional amount to the amount you drink?
Well, I think there is actually. If you drink a lot, if I'm going to drink a lot, which I very seldom do, I maybe take 2 in the beginning of the evening and 2 at the end of the evening. But
actually, I can give you the numbers that Steve Fox.
Yeah, I got this from Steve Fox.
Steve Fox.
He's the one who turned me on to this.
Yeah, and he said take 1 dose before you start and 1 with every drink. But he was talking about. Let me see. Where's your mix here? How much do you say to take?
I just said 1 to 2. I didn't put down how many milligrams. Whatever, 5 or 600 milligrams.
I think he was saying 600 milligrams of vitamin C and then something like 200 acetyl L-carnitine. Is that right?
No, it's N-acetylcysteine.
That's right, N-acetylcysteine.
Yeah.
I think his mix was 600 milligrams of vitamin C and 200.
Yeah.
For every drink.
Right.
And then 1 to finish up.
Right. Well, one thing I like about this NAC in the alcohol is that, we do a lot of stuff and we kind of do it on faith. We read the studies, we hear the reports, and we say, okay, well, this is the biochemistry of the body, this is how it works, so we'll take lycopene because it does this in your body. But now here is a case where you get instant results. So if you ever doubt that, you can intervene in your biochemical processes, which is really what our basic strategy is in this group, this is a kind of a good, exercise. And as we're going to talk about something else, which is even more amazing tonight. And in fact, 2 things. the two things I want to report on is a follow-up to John Ferber's report about iron chelation of 2 months ago. Remember we talked about that? And he said that they had done work with Alzheimer's and it looked like iron overload was a factor in the brain. Anybody remember that?
Yeah.
Yeah, and then we set up a committee, and the committee didn't actually ever meet, but I had the good fortune to go up to the Buck Institute about, I guess it was a week ago last Tuesday, with John himself, and we were able to talk about this some more. So I wanted to give you a report on that. Now, let me just ask one more time. Is Dr. Klindt in the house? Okay. I want to kind of like not cut into his time. Now, remember Alzheimer's is something we spent some time on because Steve Fox has his own theory and some very good evidence to support the view that mercury toxicity, mercury in the brain, leads to a destructive process whereby the neurons which depend on a certain substance called tubulin are damaged. When the mercury hits the tubulin kind of collapses and loses its structure. And he thinks that's what initiates Alzheimer's. Now there's another theory which isn't in competition with it necessarily. And that theory is that there are certain transition minerals in the brain, especially copper and iron, which produce oxidation. They're known to be oxidative factors. There's certain oxidative processes, and when iron or copper is present, there's a lot of free radicals produced and other damaging, what do they call them? Radical oxygen species, I think they call them, ROS. But anyway, basically free radicals and some other reactive oxygen species, right? And so what John Ferber said was that they had done these experiments using a drug called cleoquinol. I'll spell it for you. It's C-L-I-O-Q-U-I-N-O-L. Cleoquinol. Now, cleoquinol, turns out, was used very widely, millions and millions of prescriptions worldwide for parasites, and it killed parasites. And it's now been determined that cleoquinol chelates iron out of the body. Now, it turns out if you look at copper and iron, there's twice as much iron in the brain as there is copper. And even when it's, accumulated and overload. So that iron is probably the bigger factor, although copper is a factor too. But I suppose, since they're very similar, that usually what chelates one transition metal, certain kind of molecular structure, chelates the other. So that, for example, alpha lipoic acid, which we're going to talk about in a minute, chelates iron, it also chelates copper, also chelates cobalt, and also chelates mercury, as a matter of fact. But now, what they did was they used cleoquinol on human subjects, and they got a reversal of plaque, and they also got a dramatic improvement in performance. And this work was done, John didn't have a chance to go into it, but I talked to him, I got the names, and I went on the web, and I can tell you where to find it. It was done by an Australian who went to Harvard, is now at Harvard. His name is Ashley I. Bush. So, I mean, with a name like Ashley, you'd have to be Australian or English or something. And he's done a lot of research, and he's been working his way toward this position where he is now, where he thinks that iron is the problem. Now, as it turns out, the body does not have a good way to sequester, bind up, and get rid of iron. It's got a fairly good way to get rid of copper and some of these other metals, but I talked to Steve Fox about this, and Steve said that iron is a problem. As a result, as you age, the iron in your brain accumulates. In fact, it accumulates all through your body, but it also accumulates in your brain. And since it's an oxidative factor, it seems reasonable to suppose that as you age and iron accumulates in your brain, the oxidative stress on the neurons increases. Now it's known, for example, just came out recently, that curcumin, the spice, is protective against Alzheimer's, as is vitamin E, and as is ibuprofen, all of which reduce inflammation. Now, the fact that they reduce inflammation suggests that what they're really doing is protecting you against the oxidative stress, because when oxidation occurs, that's when you get inflammation. That's one of the major reasons why you get inflammation. So that, in a way, also supports the idea that iron might be behind a lot of Alzheimer's, as well as Parkinson's. Because Parkinson's, as you may know, comes about when a small portion of the brain, called the substantia nigra, the substantia, the substance, nigra, dark, the dark substance. When that small part of the brain, those neurons, those substantia nigra neurons, start to die, and those are the very neurons which produce the neurotransmitter dopamine. And when you lose too much dopamine, when it gets down to 30% of what's normal, you start to have Parkinson's symptoms. Now, as it turns out, let's talk about Parkinson's for a minute. After the age of 40 or 45, every decade you lose 13% of your dopaminergic neurons, of your substantia nigra. Now, why is the substantia nigra dark? Because of the heavy concentrations of iron, which are found more than any place else in the brain. You find iron in the substantia nigra. So, again, iron is implicated here. Now, one way to get rid of iron, to reduce your iron load, is to take cleopanol. But cleopanol is a drug. It actually was withdrawn after being very successful with parasites. It was withdrawn when the Japanese discovered that there were some very severe side effects. And they didn't know why, but some people died, and so it was withdrawn, and they found out later that what was happening was that the cleopanol, which is a really powerful drug power type of chelator, was removing cobalt as a trace mineral from the brain. Cobalt is required in vitamin B12. Vitamin B12 is cobalamin, cobalt plus some stuff in that molecule. So there was a radical vitamin B12 deficiency in these people who were using cleopanol for these parasites, to kill the parasites, and they were having big problems. Now, when Ashley Bush did his experiments with cleopanol, which is, you can still get it, even though it's off the market, they're giving people B12 supplementation to go with it, and they're having these dramatic results. I mean, the results are almost like, you know, this whole field is so exciting that it's almost, you just hold your breath to see if it's going to be true. But here's the other thing I wanted to say in this first, in talking about iron and ion chelation. I happen to remember an article in Clara Felix's newsletter. And I don't know why it struck me as important, but I'm kind of a file type of person, so I filed it. And what it was that Clara reported that the Linus Pauling Institute had just published an article showing that alpha-lipoic acid chelates iron. And so I went back and I looked that up. And John knew this newsletter. Linus Pauling Institute, used to be in Palo Alto. And people used to come here from Linus Pauling Institute and talk to us in 1995, 1996. Rosalind and I, many of you go back that far. But then they moved to Oregon in 1996. Well, they're going gangbusters up there, now associated with with Oregon State University. And they have it's a nonprofit organization. They get a lot of money now from the government, NIH and so forth. They're doing fabulous research. And since it's a nonprofit organization, their newsletters totally for free on the web. If you look at the spring 2001 newsletter, you will find an article by, as a matter of fact, I referred to it in my stuff, because we can talk about alpha-lipoic acid in two different contexts here. In one context is where we're dealing with the iron problem, iron chelation, and neurodegenerative diseases, especially Parkinson's and Alzheimer's. The other report I want to talk about is the ALA, alpha-lipoic acid, acetyl-L-carnitine rejuvenation technology that we're going to, I think Gladys is going to be allowed, and that's going to be also wonderful. Very exciting. But anyway, staying with the iron chelation thing. So this gentleman, Korean gentleman by the name of Jung Suk, has a wonderfully clear article, and he says at the end of his article, it's only about 3 pages long, that when they gave alpha-lipoic acid in a certain dose to aged mice, first of all, they were able to determine that the aged mice had twice the iron in their bodies and in their brains as the younger mice. By the way, they just sequenced the genome of the mouse. You may have read about it last week, they announced it. That the mouse, it turns out, is 99% the same genes as we do. Now, when they first got started, and people started guessing, how closely are related to other animals. I thought the mouse was supposed to be like 97.5, and the chimp was going to be 99%. But now the mouse is 99, and the chimp is only like, a few thousand genes of difference. But what's my point? The point is, now the experiments on mice are plausibly a good model for what's happening in our bodies. Now there's one problem when we're talking about Alzheimer's. Mice don't get Alzheimer's, even though they do accumulate iron in their brain. So, of course, that would be interesting to track that down and find out why mice don't get Alzheimer's. This is something John taught me, and I then discovered it in my reading to confirm it. But the article in the Linus Pauling Institute said that when they gave the alpha-lipoic acid to the mice, the older mice achieved an iron profile which was as low as the younger mice. That's how good it was. And it did not remove the excess iron. It removed the excess iron, but it did not remove the iron that was needed for a healthy operation. It seemed to be discriminating in that way. Are you Dr. Klindt?
Yeah.
Wonderful, wonderful, great. We'll be right with you in about 5 minutes. Now let me ask you, do you have any audio-visual stuff?
Yeah, I do.
Did you bring it?
Yes.
Okay.
This area attacks the red blood cell, which is where iron is.
Right.
And it turns out that cancer sequesters iron. And artemisinin, which is what you're taking now, oxidizes the malaria parasite and kills the cancer because the iron is there.
How does it interact with the iron,
The iron, it oxidizes.
Oh, it oxidizes the iron.
It oxidizes the cancer, kills it, and it oxidizes the malaria parasite. And artemisinin is written up in the Townsend letter, December issue, and it's sold by allergy research.
It's still a new thing you can buy in the health, I don't know if the health food stores or those channels, but it's not fully proven yet. But it's getting more and more popular, and people are talking about it. More people are using it. So it's just around about 6 months.
Yeah. Well, I'll tell you what. I wanted, it's a shame that we don't have more time because I'd like to, get your feedback and see if I've been clear about what I've said so far. But I want to just kind of briefly mention the other thing I want to talk about before we bring next week. Yeah, Mike?
I just want to mention from the conference about 2 or 3 items. There was an N-acetylcarnosine that's being used by the Russians now for cataracts as eye drops. They've had some success. They've been studying it for about 10 years, and they were selling it through the international IAS organization that's in England. It sells a lot of drugs that you have to normally get by prescription. So that was one of the popular items at the show. Another thing is there's a lab called Direct Labs.
Yeah, tell you what, Mike?
Yeah.
Would you mind standing up so everyone can hear?
Okay. There's a lab called Direct Labs that will do 50 blood tests, actually 40 actual blood and 10 ratios that you don't even need a doctor's prescription for, and that there's a guy that analyzes this full spectrum of blood much better than you would looking at normal ranges. For example, he says the conventional normal range for mineral calcium is 8.5 to 10.5 milligrams per milliliter. A blood chemistry for calcium that is above 10.5 can indicate a pathological condition such as multiple myeloma. Reading for calcium below 8.5 can indicate rickets or osteoporosis. No significance is given to the 8.5 to 10.5 range. And he says, according to bionutritional analysis, and he worked with NASA scientists on analyzing how good they were in their blood, the optimum range for calcium is 9.7 to 10.2 milligrams. A reading above 10.2 or below 9.7 can indicate digestive malfunction, which can be corrected through proper diet and supplementation. So what this guy will do, and I can give you his number later, is he can get a copy of the test. It's only $79 for the 50 blood tests. If you call a number, they take your credit card, and there's a lab in San Jose. They'll take your blood, and you don't pay them anything. They send it to this facility. You get a copy, they get a copy. Any doctor you want gets a copy. You can go through it with your own doctor, or with this guy who's extremely reasonable, who tells you not what the ranges are, but what's for optimum nutrition. He's called bionutritional analysis. I found that was an interesting thing.
Yeah.
And also I have a packet of just a summary of what they were talking about, which is a lot of the usual growth hormone. They've spent a lot of time on omega-3. That is that doesn't have the problems of the, this is it in here, doesn't have the problems of the cod liver oil. And this, and the purification I'm getting the paper on is 1 in a trillion. And that's the other problem with fish oils. There's too much mercury and other pollutants. And the statistics on this by an independent lab are extremely outstanding. So it's done in a, I forget what they call this form, this powdered form. The shelf life is 3 years if you don't open it. If you open it, it's something like
what does it cost?
Pardon? The name of this is Dry Cell DHA EPA, made by a lab called Fromax.
What does it cost?
Oh, the cost. It's about, let's see, below $20. 12 for this bottle, 150 grams. I think it was $12.
I'm sorry, who's the maker?
The maker of this is a place called Fromax, P-H-A-R-M-A-X. And they are in they're in Bellevue, Washington is their main address, and their sales office is in San Diego. You can look them up on the web, P-H-A-R-M-A-X.
How's it spelled? D-H?
Pardon? P-H-A-R-M-A-X. And I'm getting the literature on it later. So then, also, they had a lot of machines there that somebody was referring to earlier that they test different frequencies of the body. If people have heard of Royal Rife a long time ago and been discredited, they now have more sophisticated equipment that looks at people's frequencies and not only diagnose them by frequencies of what problems they have and give them a checklist of what to handle, but some of the machines will actually put back a relief for each of those problems. And they were demonstrating it in some of the giants in alternative medicine, like, I don't know if you heard of Burton Goldberg. He wrote Alternative Medicine, Alternative Cancer Healing Handbook. He was raving about it. He was taking 3 treatments at the show while he was there and raving about it, but it's still very new. There's only 6 in the country. So that's an example of some of the things. Then they took Ward Dean, if you know him. He had written a big book on aging, and they took all of the stuff in the book. Software engineers spent 3 years going through it and have 100 indicators that they will test you on and go through an analysis. And some of the doctors are getting it now. to tell you what's wrong with you. That gets into more expensive stuff compared to the $79 blood test that I was talking about. That's some of the things I was interested in.
Now, Mike was doing there, I didn't explain. Mike just got back from the A4M meeting, which is the, what does A4M stand for?
American Association of Anti-Aging Medicine.
That's right, American Association of Anti-Aging, and it's three, explain.
Anti-aging too.
Oh, anti-aging too, okay. And it's a really great conference, it's been going on for about 10 years now. And so I asked him to give a report, and he told me that he didn't know if he could be ready, so I assumed that he wouldn't be ready, so that's why I didn't call him. But anyway, that's what was going on. So if any of you picked up just little clues as to what might intrigue you, then talk to Mike afterwards, because this whole group exists for networking and sharing of communication. So if you didn't get it the first time around, don't worry, just ask me.
One other thing related to Dr. Klindt, I wonder if he has heard of something here. One of the things that came out of the show, brain expert says BEAM better suited than MRI to screen for depression. Are you familiar with BEAM? This is Eric Braverman's stuff. Do you know about him?